Good morning, everybody. I'm Francesco de Seta, obstetrician gynecologist at the University of Trieste. It's a great pleasure today to moderate this session of GLP Academy, a medical consultant in R&D for GLP. And I need to tell you that the experience of the Academy, for those who have already attended these events, has started about 4 years ago. In 2017, we have thought with Mr. Teruzzi to create periodical meetings to establish a link between industry, the research, and of course medical care. We have tried as much as possible to foster exchange of scientific evidence, experience, and research to try and understand the needs of the industry and also the needs for medical specialists when it comes to health benefits and clinical efficacy. Today, we wanted to move on in the wake of GLP Academy using remote events. At this challenging time, there was a desire not to stop this extraordinary thrust starting long ago in 2017. We have started meetings in February 2017 talking about innovation and experimentation with nutraceuticals and probiotics. In the same year, with the specialists, we tackled the topic of the relationship between probiotics and microbiome. In 2018, new topic, we have been discussing about correlation of cognitive health, longevity, and the gut-brain axis, this direct axis between the bowel and the brain. The following year, we have moved forward. If you were attending, you will probably remember the new aspirins of the 21st century. The industry is proposing probiotics, melatonin, omega-3, curcumin. But what is the scientific foundation for the use of these ingredients in clinical practice? As a matter of fact, starting from these new aspirins, we have thought of tackling a common word, epidemics. We are experiencing a real pandemic this year. We would like to debate over the so-called silent epidemics. The desire was to organize several webinars. This is the first one to address various topics like metabolic syndrome, GERD, microcirculation disorders, and the topic for today will be slightly different. With our expert, we will be addressing the topic of whether we have a silent epidemic. We will be talking about recurrent UTIs. When drawing up the agenda for this meeting on UTIs, I have immediately thought of a colleague and a friend, Professor Stefano Salvatore from San Raffaele Hospital in Milan, that you all know because he's a well-established expert in this sector. It's a great pleasure to introduce him at this challenging time. We want to restate our presence with this first webinar, and it's a great pleasure to give the floor to Stefano, who will be talking about recurrent UTIs. Good morning, everybody. I would like to thank Francesco for introducing me. We are really close friends, not only colleagues. So that's the reason why I have accepted to share this event with you. I would like to thank GLP for giving me this opportunity. The talk today will be mainly on UTIs. urinary tract infections with major prevalence and epidemiology, they pose a clinical challenge which is really difficult to tackle. It's sometimes frustrating and, of course, very, very annoying for the patients. I am gynecologist and obstetrician at San Raffaele Hospital in Milan. I deal with Urogynaecology, with pelvic dysfunctions in women, and among them UTIs play a central role. Now I would like to share some slides with you. The main topic of the talk today will be treatment, most of all non-antibiotic treatment of UTIs. After a short introduction, I will give you an overview on clinical evidence and the guidelines of the international scientific societies and the products that are commonly used in clinical practice. Trying to foster discussion afterwards and talking about use of various ingredients and approaches in management of UTIs, which would require a systemic approach. UTI is an infection in any part of the urinary system, could be the upper or the lower urinary tract. That's very important for gynecologists because women, out of anatomical, embryological, estrogenic features, and because of their receptor status, are often affected by UTIs. 40 to 60% of females will develop at least an episode of UTI in their lifetime, with an incidence of 5% per year. There are some age brackets where these events are more frequent. Most of all, when women start having sexual intercourse, then a menopausal transition or postmenopausal period, or in older age. I have forgotten to mention that this is just an informal and possibly interactive talk. I would really like to discuss your questions after the presentation, so that we complete the topics to be presented and discussed afterwards. We have said that UTI is a common disorder affecting many women, and as a matter of fact is one of the most important items of expenditure for the healthcare system in the US. We can have asymptomatic bacteriuria or acute urethral syndrome with the symptoms that are often overlapping, except for pyuria and dysuria along the urethral tract. The most frequent condition is commonly defined as a cystitis, with involvement of the lower urinary tract of the bladder first and foremost. And when we have the upper tract that is affected, the most frequent condition is pyelonephritis. From a classification point of view, we need to differentiate UTIs between complicated and uncomplicated. So we can have UTIs in healthy women. Complicated UTIs usually occur in women with genital prolapse, diverticuli, or also posterior wall of the vagina that is prolapsing, or neurological disorders, or women who are under treatment with indwelling catheters or who are self-catheterizing. The real challenge in UTIs for clinicians is to manage relapsing UTIs. for several reasons, because of the features of the pathogens, Enterococcus fecalis and Escherichia coli, which can penetrate inside the transitional epithelium in the bladder. You have recurrent episodes of UTI. So there is a relapse. The same kind of pathogens reappear after breakdown of the transitional epithelium, and therefore they reappear after targeted antibiotic treatment. But you can also have reinfection, that is a presence of various bacteria after 14 days from end of the treatment for previous cystitis. How do you perform a diagnosis in a patient with symptoms with no recurrent UTIs? Usually, a commonly used method in the Anglo-Saxon countries is the urine dipstick with a sensitivity 77 to 92% and specificity 70 to 94%. When you have leukocyte esterase, nitritis, and presence of blood in the urine. The most commonly used method in case of recurrent UTIs, when you have to identify the pathogen causing the infection, in the lower urinary tract, we mainly have Enterococcus fecalis and Escherichia coli. You perform a urine culture at various concentrations of bacteria depending on the clinical picture. Urine culture is, of course, a very important test to be performed to identify the causing pathogens. This also allows to have an antibiogram. That is to say, it's possible to select a targeted antibiotic treatment based on sensitivity data, at least in vitro, of the antibiotic against the pathogen causing UTIs. We all know, as Francesco already mentioned during his introduction, that this is a world where everything is changing because there are increasing antibiotic resistance of pathogens. A warning of the World Health Organization was issued in 2015. There is a global surveillance and research group to improve evidence on identification of antimicrobial resistance. Therefore, there is a collective effort to try and manage complicated UTIs or to prevent complicated or recurring infections by using non-antibiotic agents or remedies. And of course, there is a broad use of non-pharmacological agents, as you see on the right-hand side of the slide. We will cover all of them, and in a specific population, local estrogen replacement plays a central role because it restores trophism of the vagina, of the uterus, with the estrogen receptors that tend to become silent in menopause because of the hormonal changes. And the idea is also to recolonize the vaginal tract with the lactobacilli to restore normal pH value of the vagina, which is extremely important as a defense barrier against pathogens in the urinary and vaginal tract. Common pathogens are Enterococcus fecalis and Escherichia coli, that is to say, pathogens from the intestinal tract. colonization of the vaginal tract and of the urinary tract in women is more frequent. It happens through lymph vessels and out of proximity or during sexual intercourse. Therefore, it is very important when you have to treat UTIs in women to keep in mind that, as Francesco said earlier, there is an increasing understanding of the brain-gut axis, and there is also cross-talking between the rectal, vaginal, and lower urinary tracts. And from a clinical point of view, you cannot manage patients with recurrent UTIs trying to treat just one of these three tracts without also involving in your treatment protocol the bowel or the anal region that are a reservoir of pathogens which need to be addressed. Otherwise, they will cause reinfection. During our talk, I would like to accompany you through scientific evidence. We will share the guidelines of American and European societies addressing evidence and the various active ingredients excluding antibiotics. While preparing this talk, I was a bit discouraged because, as we will see later, European guidelines are sometimes contradictory, they are different from American ones, and there seems to be different interpretation of data in literature. Even if there are very high levels of evidence in the clinical trials addressed by the scientific societies, starting with the AEU guidelines dating back to 2018, we see that the approach in treatment of lower UTIs without complications, the two agents with a higher level of evidence, the recommended ones, are local estrogens with 1B level of evidence and immunostimulating treatment through lysates of 18 strains of E. coli with 1A level of evidence. These are the only two elements which are strongly recommended by the AEU, the European Association of Urology. The American Society of Functional Urology, on the contrary, recommend use of local estrogens in women in menopausal transition or after menopause. But looking at non-antibiotic prophylaxis, the guidelines don't mention immunoactive ingredients. They rather focus on cranberry, and the recommendation in the American guidelines with level of evidence C is use of cranberry to prevent recurrent UTIs. Looking more in detail, we see that estrogen replacement in the lower box of this slide in older Cochrane reviews reflects evidence that estrogen replacement through vaginal cream or vaginal ovuli with a 17-beta estradiol or more recent products based on estriol proved to be consistently effective in the guidelines. There is a consensus that a local estrogen replacement is useful in reducing incidence of lower UTIs, most of all in recurrent forms. Ratz published a paper in New England Journal of Medicine, a randomized clinical trial, producing plenty of evidence supporting use of these treatment protocols. To summarize a little bit later guidelines, looking at more recent evidence, there is a meta-analysis dating back to 2020, assessing 5 RCTs on almost 2,000 patients using vaginal estrogen-based cream, and there is a consistent reduction in RUTIs, so compared with placebo. Local estrogen replacement is very useful in postmenopausal women, but there is some reluctance among women in making longer-term use, in being compliant with this treatment, but that's yet another story. Preliminary studies are now available. They have started in 2018 about use of OSPEMIFENE in preventing recurrent lower urinary tract infections, and data are quite promising, but this is just one study published by Italian authors over 6 months, and OSPEMIFENE has not been introduced into the flowcharts of European societies, and this therefore proves that we need additional evidence supporting its use. One of the commonly used products both in Europe and in the US are cranberry products. Cranberry can inhibit adherence of E. coli to the transitional epithelium of the bladder walls by activating protocyanidin, which sticks competitively on these cells as opposed to E. coli. Cranberry in Europe has been more successful or less successful depending on the time. And this is also reflected by the fact that one of the latest Cochrane reviews and the latest guidelines of the European Urology Association do not recommend use of cranberry products in preventing symptomatic UTIs and in preventing recurrent UTIs. The American guidelines or the Canadian guidelines, on the contrary, recommend use of cranberry products with a C level of recommendation. A recent document dated last year is supporting use of cranberry products. As a matter of fact, clinical evidence that cranberry products lead to improvement of treatment outcomes in UTIs is available. There are 2 RCTs before other studies addressed by the European Society showing that cranberry products are superior to placebo in preventing UTIs. In a meta-analysis of 2019, analyzing 7 RCTs, the conclusion is that cranberry products can play a role in healthy women in preventing non-complicated UTIs. Cranberry has also been combined with other ingredients like propolis, which act in combination with the cranberry, inhibiting adherence of E. coli. It also acts on formation of bladder biofilm, another important target of some treatment protocols. It acts on iron metabolism, and it also acts on stress response of uropathogenic E. coli. There are very promising, very interesting studies showing that combined use of cranberry and propolis can help prevent UTIs. Another RCT of 2019 shows that in the first 3 months there is a significant reduction in the incidence of recurrent UTIs combining propolis and cranberry. We have said that a non-antibiotic treatment of UTIs, at least in women, can be proposed by immunoactive prophylaxis. Despite all the logistic problems, we are collecting data on efficacy of Urovaxom, which is a lysate of 18 strains of E. coli. Using Urovaxom, you have a significant reduction of recurrent UTIs. The drawback of this immunoactive prophylaxis is that none of these 3 elements is commercially available in Italy. Urovaxom can be bought by patients in any other country within the EU or in the Vatican State or in San Marino. For some reason, pharmaceutical companies have decided not to invest in Italy, and that's the reason why we don't have this treatment in Italy. It's a lysate of bacteria. Urovac is a vaginal cream containing E. coli, Protozoa vulgaris, Klebsiella pneumonia, and so on and so forth. In Italy, we have an oral product which tries to foster colonization of the bowels with a normal E. coli. This treatment is showing very promising results, and I believe this kind of prevention can be very effective and should be recommended as successful. But all of that needs to be combined with other treatment approaches that we will be addressing during the discussion. As to immunoactive prophylaxis, with ingredients we have covered so far, there is a certain level of evidence. There are 3 RCTs on Uromune, which is a sublingual product, 9 RCTs on Urovaxom, which is administered orally, 1 tablet for 3 months, and Urovac is a vaginal product which needs to be administered over 3 months, leading to significant reduction of UTIs at 6 months. That's the duration of the follow-up. I would like to remind you that considering the guidelines, the European Association of Urology, a very important scientific society for urogynecologists, our reference society, provides a very high level of evidence, 1A for Urovaxom, in reducing recurrent UTIs. Therefore, the society recommends it. Completely different approach 1 year later by the American Urological Association, the Canadian Society, and the Functional Society in the US. Another very important aspect to be considered in prevention of UTIs is the fact that, as we said earlier, there is a cross-talking between the anal tract, the urinary tract, and the vaginal tract. There is a closed system, as Francesco has already proved several times. Improving vaginal dysbiosis allows to have a beneficial effect also on the other tracts. It also helps reduce recurrent UTIs in women affected by this disorder, improving commensal bacteria as lactobacilli. Having said that, there are, of course, more recent studies where very well-established scientific societies say that there isn't enough evidence to support use of these ingredients in patients with relapsing infections. Lactobacilli have been object of several clinical studies, most of all in vaginal disorders and also in urinary disorders, and lactobacilli are also studied in terms of presence in the urinary tract, and the contribution of individual bacilli against infections is now being researched. There are several clinical studies. Lactobacilli are bacteriostatic. They help down-regulate expression of virulence genes, and they have a bactericidal effect. We have said that use of vaginal lactobacilli helps reduce vaginal dysbiosis and also has an effect in reducing recurring UTIs, also through an intravaginal treatment. So intravaginal treatment can be effective and beneficial also on the lower urinary tract. Lactobacilli that are most effective are Crispatus, rhamnosus, and Reutelidus. One of the most interesting things we'll need to explore in the future is whether we can develop treatment with lactobacilli for the urinary tract and for the vaginal tract, so as to reach a higher efficacy of Lactobacillus crispatus, which has been detected in urine of healthy individuals and to a lesser extent in women with UTIs or women with functional disorders of the bladder, where the microbiome can therefore play a central role also in physiopathology of functional disorders like a hyperactive bladder after chronic lower urinary tract infections. Another commonly used ingredient is mannose. It needs to be taken in very sustained, very high dosage to be superior to placebo. In 1 RCT, 2 grams of mannose every day seem to have a preventive action, so the same as a 50 milligram of furantoin. Looking at the guidelines, you can see this slide, which is a bit confusing. I apologize for that. Only the European Society of Urology some way seems to recommend, with a lower level of evidence, use of mannose, while the American Society does not recommend use of mannose. Quite recently, in 2020, 1 RCT has been published on mannose with protocyanidine as opposed to protocyanidine alone. The combined effect of these 2 ingredients seem to help prevent recurrent UTIs. This is, of course, a first topic which can be discussed later during the Q&A, that is to say, treatment and prevention protocols of UTIs, which, in my opinion, should include a set of elements to promote well-being of the urinary, vaginal, and anal tracts, inhibiting reinfection of these 3 tracts. One of the mechanisms to achieve that would be an intravesical instillation of chondroitin sulfate acting on the biofilm coating the cells of the bladder transitional epithelium. There is increasing evidence of intravesical instillation of hyaluronic acid against recurrent UTIs. In my opinion, this instillation is not very effective in acute UTIs. Other clinicians are of a different opinion. Hyaluronic acid is also anti-inflammatory, but if we need to restore the biofilm coating the bladder epithelium, we should rather look at other agents and use this only in prevention. For the sake of completeness, I would also like to mention other approaches. Researchers are exploring the role of vitamin D, of ascorbic acid, of herbal treatments in preventing urinary infections. As of today, there is no sufficient evidence to recommend use of these compounds, but it would be misleading to focus on just one of these elements or one of these agents in prophylaxis in preventing this multi-compartment disorder, which requires a full-fledged systemic approach. By way of conclusion, we can say that great efforts are being made by companies in research to minimize use of antibiotics. Increasing AMR, most of all by certain strains of E. coli, makes it very difficult to manage patients with these disorders. For patients, but also for clinicians who are often frustrated because they do no longer know what they could propose to their patients. There is increasing evidence about the use of immunotherapy, CRANBERRY and PROPOLIS, which could be used in combination, and then reprotecting the bladder through instillation of hyaluronic acid. For sure, there are also other products that are being studied. They show promising results, which of course needed to be validated before they can be introduced into everyday clinical practice. That's all for me. I would like to thank very much the people who have been following this webinar. There is still much to do, as you have seen, but there are also many opportunities with a multi-compartment combined approach with all the weapons we have in our armamentarium. Thanks, Stefano, for this nice presentation, sharing the broad spectrum of treatment approaches in recurrent UTIs, most of all in the light of AMR. In Italy, we are unfortunately leading the ranking list, and that's the reason why we need to switch to non-conventional active ingredients against UTIs. There seems to be indications and conflicts or divergence among the scientific societies. So European guidelines are in favor of certain approaches which are criticized in the US and the other way around. Based on what you said earlier, Stefano, mannose and similar substances can represent a promising starting point. While you were talking, we have received some questions. I will read out the questions and you will then answer. A colleague is asking, is there a correlation between UTIs and gynecological or obstetrical infections in general? Yes, I would like to underline that any dysbiosis, Francesco, you know better than me, and I would like to hear from you. Any dysbiosis affecting the bowel or vaginal tract has an impact on the urinary tract as well. And this applies to any episode of UTIs in any age in women. When we have recurring UTIs, there are different treatment approaches. We look at disorders, defecation problems, or colitis, which pose a risk factor, of course, for UTIs. Vaginal dysbiosis or vaginal infections are often associated with recurring UTIs. And once more, this shows that if we want to win this clinical battle, which is sometimes discouraging us, if we want to win our battle for prevention, we shouldn't forget to look at the whole armamentarium of weapons we have. We need to address the bowels, the vaginal tract, and also the urinary tract. We shouldn't neglect any of these three elements, otherwise we would be in a vicious circle. I fully agree with your comments. The various axes, the brain-gut axis reflects the importance of the interaction of the cross-talking between the urinary tract, the vaginal tract, and the other compartments. There is a direct correlation between bowel reservoir infections and vaginal disorders. Think of E. coli, recurrent infections during a pregnancy, or obstetrical sepsis. There is a close correlation. I fully agree with you, and I would like to expand on that. There are at least a couple of papers showing that after delivery-induced sequelae, the perineal body between the anal fork and the urinary tract seem to be a risk factor. There is a higher risk of cross-contamination if the distance is reduced between these two tracts after delivery. And this can be addressed. We have anecdotal evidence of behavioral interventions, of intervention on the bowel function or rehabilitation protocols. You were commenting delivery sequelae where you have a shift of the perineal body can make women more prone to UTIs. There are several questions like control of the urinary pH value. Should we acidify or not acidify? What's best? Urogynecologists rather look at the vaginal pH value. The urinary pH value is not commonly considered because it's a consequence of the alteration in vaginal pH. There are now studies on an energy-based device in preventing recurrent UTIs in women, together with a British university, and in a brainstorming effort to try and use this energy-based device with the vaginal approach, the idea was to restore physiological pH value of the vagina, so between 4.5 and 5.5. Urinary pH value doesn't seem to play such a central role. There are no clinical studies, no significant studies on that. The idea is to acidify the urine. There are urine acidifiers. But as you have seen earlier, what's the cause of a vaginal acidification? You can buffer temporarily an epiphenomenon, but I don't know whether this is really successful as a treatment. This is just a short-term effect without removing the pathophysiological cause, so it can help. Okay, there was also a question about oncological patients, UTIs, recurrent UTIs in cancer patients. We see many of them, unfortunately. If we talk about cancer patients receiving chemotherapy, you know that these patients are often difficult to manage. What is your advice? In cancer patients after radiotherapy, where there are changes in the lower urinary tract, where bladder elasticity, bladder function can be altered, where the biofilm composition is changing, we try to act by instillating hyaluronic acid in order to recreate something which has been altered by treatment. Intravesical instillation of hyaluronic acid can be combined with other approaches we use, like administering Lactobacilli, crispatus. We also administer ECN, which is E. coli that we have in Italy. And in our clinical experience, I need to acknowledge we haven't published any studies on that. In cancer patients after radiotherapy, you can also have relief of symptoms, which is an important target of our treatment. If we instill the bladder with hyaluronic acid, patients become more bladder compliant because bladder compliance is impaired in this population of patients. There was yet another question. We have started discussing on lactobacilli. So there seem to be some studies promoting vaginal use of lactobacilli. We are very much in favor of this bowel-focused approach. We need, of course, to explore regulatory mechanisms, and this needs to be done with clinical studies. There is a conflicting evidence. What's your opinion on that? Well, of course, I can answer to this question giving you my very personal opinion. There is no comparative study on that. And I believe we are using vaginal lactobacilli and lactobacilli administered orally. We use both products, both routes of administration, because also in oral administration we have seen that it's possible to have isolated vaginal crispatus. I don't know what's best. There is no scientific evidence in favor of one of the two approaches, no conclusive figures on that. With probiotics, the target needs to be to correct dysbiosis of the three compartments. My dream as a urogynecologist is that in quite a near future it will be possible to instill lactobacilli into the bladder to have even superior efficacy in the lower urinary tract and to avoid functional problems which have been observed and recorded when you have a chronic inflammation and recurrent UTIs. This morning, Stefano, we were discussing about the future option of graft of a vaginal microbiome in preventing recurring UTIs. This is a future option. Vaginal lactobacilli seem to be very promising, but if I had to choose, probably most of all in chronic patients in recurrent UTIs, the bowel reservoir should be managed, should be monitored. You have mentioned cranberry and propolis in combination. Is there any contraindication in pregnancy? No. No contraindication in pregnancy against the use of both ingredients. I would like to stress that in Europe, unfortunately, the European Society of Urology does not recommend to use cranberry-based products, but there is increasing evidence also based on RCTs that cranberry combined with propolis can help counteract UTIs. We administer cranberry during breastfeeding, during pregnancy, no contraindication. There is also a question, as we have been talking about the important role of biofilm, when we talk about the products we use against UTIs, how can we handle the bowel reservoir? How can we impact on the biofilm, on the urothelium? What should we choose? How important is the effect on biofilm? We are referring to uropathogenic biofilm, not protective biofilm. Well, a physiopathological premise on that. E. coli and Enterococcus fecalis to a lesser extent in patients with chronic inflammation can break the biofilm to reach the transitional epithelium. This is a major problem, of course, if we want to fight recurrent infections, as a transitional epithelium is subject to turnover, and when we treat cystitis or urinary infections of women for 3 to 7 days, depending on the protocol, can also be 1-day treatment. If we have tissue turnover, E. coli is able to proliferate and there is a new urinary infection. The European guidelines suggest that for prevention of recurring UTIs in a patient with these symptoms, with this problem, you should consider the cycle, the duration of turnover, 4 months. The European Society of Urology suggests to administer a low dose of antibiotics, so that when there is a cell breakdown, a cell turnover, pathogens start proliferating, and you need to have a minimum dose of antibiotic. So quinolonic, Bactrim, fosfomycin, and nitrofurantoin are part of this antibiotic protocol. in the period of prevention, but this is, of course, my personal opinion based on clinical experience, over these 4 months, we combine all of the products which interfere with bacterial adherence to the epithelium. The biofilm has already been damaged by then. Mannose, cranberry, methionine can be administered. There isn't actually much evidence of methionine. We administer also lactobacilli, and we try to restore normal function of the gut. After 4 months, when we try to control the vaginal tract, the bowel tract, we antagonize E. coli in the bladder, making it difficult to survive with a low dose of antibiotics, or by administering elements inhibiting adherence of E. coli. After this cycle of 4 months, we try to stop, to block the way to E. coli. There can be an overlap at the end of the 4 months. We can rebuild the biofilm by using compounds containing hyaluronic acid with a special formula used for intravesical instillation. Administration of systemic administration or oral administration of hyaluronic acid, well, I'm quite skeptical, because only a very tiny part of that will reach the bladder, and it's probably not sufficient. So my attitude is to make these pathogens in the bladder life very difficult, controlling vaginal and rectal infections as much as possible. And at the end of the tissue turnover, we try to close the way, overlapping the dose of antibiotics and agents inhibiting adherence. There are more questions. I would like to give my input. I have received a WhatsApp message. You have been very generic on probiotics. It's not that we wanted to be generic on probiotics. You have been very straightforward, very honest, Stefano. When we present data, there is always a certain level of evidence associated with these data. Stefano has shared evidence on other ingredients. If we look at probiotics and in fact on UTIs, we have a different level of evidence. There is individual clinical experience, but Francesco, I would like to step in. You know, we shouldn't convey a misleading message. We can have recommendations and scientific evidence. No scientific society internationally recommends to use probiotics in recurrent UTIs. If you ask me about my personal opinion, it is that probiotics can be very useful, but they are not the only element in treatment and prevention for all the reasons we have addressed earlier. You cannot think you can step into the realm of E. coli using just infantry. You need to use Navy and the Air Force, all the weapons you have. And in my opinion, this is really the distinctive feature. There is lack of evidence on many of the tools we have against UTIs. We have focused very much on individual ingredients in a battle that you cannot win on your own. That's true. And there is yet another question. There are actually several questions. There is one on evidence about use of probiotics in the vaginal tract. So bowel probiotics, vaginal probiotics. There are, of course, good reasons for using them. Probiotics are no longer regarded as lunch in the box to feed good microorganisms. They have a filmogenic immune modulating action. So this is a very, very useful question connected to Stefano's comments earlier. I would like to underline that we now need to find effective prevention strategies requiring combined protocols. Our effort needs to find the magic recipe so that each product with distinctive features makes it difficult for pathogens to reinfect the urinary tract in women. Of course, and this also takes me to introduce other questions. So there was another question. Okay, we have stressed the gut reservoir. Is it just a proximity the cause, or can there be transmucosal lymphatic migration or any other migration mechanism of these pathogens? There are studies by urologists showing that colonization of the lower urinary tract can also occur through lymph vessels, not just because of adjacency. You have been talking about probiotics earlier. There is another question. You have been talking about various strains and the importance of crispatus, but most companies are now producing different strains. There is just one company producing strains of crispatus. What's the reason for that? Well, this requires a longer talk, but I would like to underline that also Stefano's figures about use of crispatus, use of probiotics, it might sound rhetoric, it's very much strain dependent. Stefano was sharing some figures associated with a specific strain of crispatus, which does not mean that with any strain of crispatus you can have the same result. And then crispatus has got very short survival. It's difficult to manage. It has got a limited shelf life, and that's very, very important. We have promising data against urinary infections. We could use other strains of other probiotics, so we should consider the important role of the vaginal and also urinary reservoir. E. coli has been described by Stefano earlier. With reference to that, I can only confirm what you suggested short ago. There is no disclosure to make here, no conflict of interest at all. The interest of urogynecologists is focused on crispatus because there is an increasing number of papers published by American groups where they correlate presence or absence of crispatus and development of a hyperactive bladder or stress incontinence in patients with recurrent UTIs, and there are non-responders or responders, and these two categories of patients seem to be associated with presence or absence of certain lactobacilli. This is a red-hot topic in functional urogynecology. Two questions that I would like to merge. We have longer recurring infections with treatment protocols of more than 4 months, so maybe antibiotics combined with supplements or probiotics could be beneficial. And the second question was actually in the light of the physiopathological mechanisms that you have well described, could a combined approach be more effective? For sure. It's worth repeating it once more. We see many patients with recurring UTIs. Our protocol is not just a vaginal lactobacilli or a lactobacilli per os or MANNOSE. We have a combined treatment protocol acting on various systems and tracts. When we see patients, these patients have already tried first level treatment protocols, and usually we administer low dosage antibiotics as recommended by the AAU and also by the European Board of Oncology and Gynecology, and when possible, when accepted by patients in menopause, we also administer local estrogens. It's a package of treatment approaches that we recommend there, and all of these elements are equally important. It's misleading to read the guidelines or the messages which have been conveyed, the comments on these guidelines. Once more, you cannot expect that a single element can help solve all of these problems associated with recurrent UTIs. Let me just refer to that. So it's a composite target that we need to have in mind, which means dissolving uropathogenic biofilm, inducing formation of a protective biofilm, effective antimicrobial immunomodulating anti-inflammatory action, synergy not of CRANBERRY or MANNOSE, but a synergy of different elements that can help address this composite target could be helpful in treatment of recurrent UTIs. There was also another question, possible data on hibiscus. Do you have recent information on use of hibiscus in urinary infections? Maybe I have missed studies on hibiscus in my review of literature. I agree with you. There are some lab data or some pilot studies on hibiscus treatment, but there are also other substances which have been explored. So we should look at evidence-based medicine, at clinical practice. The hibiscus can be promising, but there is no clear indication to its use so far. Yes, it's worth specifying that. We should really reframe a little bit our talk so far. I have been talking as a clinician today, and we have the professional moral duty to act in respect of clinical evidence. We need to improve, of course, as much as possible treatment efficacy by using different products, responding to a certain treatment rationale. But I would like to restate, we have been talking about clinical approaches, about the principles guiding us in clinical management of outpatients turning to Urogynaecology centers for recurring UTIs. Stefano, by way of closing, we are really fully in tune as colleagues. You have really taken my scene. You have anticipated my closing comments. We are clinicians. So what we should ask the industry and researchers is to be driven by moral principles, by clinical, randomized, double-blinded trials to have a consistent evidence on efficacy. And this was actually the starting approach for these academy meetings since 2017. There needs to be a close cooperation between companies, clinicians, and researchers. Sometimes the companies don't understand what clinicians are demanding, and the other way around. We need to promote mutual understanding. We need to find a meeting place to be sure we promote effective treatment to the benefit of our patients. With your support today, we have taken a critical eye, and I fully agree with your comments on this silent epidemic. Would you like to close? I would just like to thank you very much indeed for inviting me. I hope I have conveyed clear messages on our attitude. I would like to restate that cooperation with companies searching for higher evidence is more than welcome, as it's always the case. We need to have a two-way dialogue, and for sure we can improve management of these patients based on clinical evidence of a higher level. Well, when we attend congresses, sometimes discussions reflect the real value of presentations, and we have never received so many questions during a GLP Academy session. It means that listeners haven't understood anything of my presentation, or that my presentation has stimulated a debate. For sure, during the next events, we will move in the wake of continuity. We would like to thank you very much indeed for following us. You will be contacted by GLP. There will be other events on metabolic syndrome, on GERD, on microcirculation disorders, which will be the topics of the next webinars. Thank you very much indeed for joining. I would like to thank GLP for allowing me to moderate these events over the last 4 years. See you soon.